Would that be okay?
Absolutely.
All right. Dr. ANJOO CHOUDHARY is going to talk now about the Indian experience in managing laryngeal webs.
For the introduction, thank you, Dr. Thiru and the Chennai Airway team. And hello, Professor Rutter, Dr. Kalan. Good evening. So I'm going to, Dr. Thiru asked me to talk about the Indian experience in managing laryngeal webs. So I'm speaking after Professor Rutter, so it's a daunting task. But he's covered most of it. I would like to show the Indian scenarios where how patients present to us and how we deal with them. At the outset, I would like to, this is the two places I would like to show. It's Sefi Hospital and SRCC Children's Hospital. These are the two places that I work at, and this is my team. Everyone knows Professor Monier. I've been trained under him. He's my mentor, part of our team, and Professor KK Ezi. We work at these two centers. I would like to say that I was in 2020 in 2020 March, I was with Professor Mike Rutter at Cincinnati just before the pandemic hit, and I was in his OR and I asked him, sir, should I stay back or should I go? And he told, go back to your family, go back to your country. That was the best advice he gave me. I came back to India on 16th March 2020, and then this is the data that we've collected after that. So this is my country, India. Now, a lot of things have changed since the last 15 years. Many airway centers have popped up. Many are doing excellent work. There are many more that I have not listed here. Now we are getting different anomalies, and these children present with at various stages. If we compare the worldwide incidence, Professor Rutter also said that it's around 5% of all the congenital laryngeal pathologies. In India, we have very few publications, but I could collect one publication which said it's around 1.5%. So maybe because the early ones do not present to us, or we are not doing enough endoscopies, and the late ones they present are very few reported and very few centers are operating. Another data is that the age at diagnosis in the Western countries is usually at birth or in the first few months of life, but in India I think we are seeing them a little later, around 1 to 5 years of life. So I'll talk about our plan, how we manage them. Essentially the same. Type 1 we would like to wait and watch. Type 2 we can wait and watch and SOS do a keel endoscopic excision with keel at a preschool age if the parents want some voice improvement. Type 3 we would like to do a double stage, and I'll say my reasons for that. Double stage LTR with anterior graft with the stent, and type 4 double stage LTR with anterior graft, SOS a posterior graft. I have my own reasons for them. So in India, we essentially see these two scenarios when these patients come to us. These are congenital webs. So in the first scenario, these babies are delivered at local obstetric centers where there are no diagnostic tools. There is hardly any understanding of the problem, and aphonia is not appreciated as much, or weak cry is not counted as a significant symptom. And also they do not have a good NICU, PICU backup at their center. While there is another scenario like in bigger centers where we have developed airway centers and we have best of equipments and good training and understanding, good backups. We also have stents available where we are well equipped to manage all the grades of webs. So I'll show cases of each scenario. So this is my first case. In 2019, this child was born after 2 previous seizures. The baby failed to cry. This was the history given, and went into a little bit of distress. They tried to intubate but failed. So at that point, they inserted a Ryle's tube thinking that there is some laryngeal anomaly, and they had to pass some tubes. They could only pass a Ryle's tube. They attempted a tracheostomy which took about 20 minutes according to the local pediatrician, that they called a surgeon, and around 20 minutes they lost. They couldn't put a tracheostomy, but they could at least pass an endotracheal tube through a small stoma. And then they transferred the baby to a local tertiary center, and he was observed for a day. And in that day, they did a CT thorax and they diagnosed him as partial tracheal agenesis. Now, this is quite hard to believe that this would be the case, because I don't think a child with partial tracheal agenesis can actually survive for 20 minutes without an airway. So this must have been some kind of an error here. Then the next day, they could actually do a formal tracheostomy on 3.0 tube was inserted, and there's no bronchoscopy available at that center. So this child later, after a few months, came to us, and then we scoped him. So he still had that RT in situ because there was no one to diagnose the problem, and this is what we could see. So it's a thick congenital web, and we can see that acquired component here, which Professor Rutter was talking about, that there is scarring because of the attempts of intubation that was made, the failed attempts. So it's a thick congenital web, and this is the distal trachea. After removing the tracheostomy, if we see distally, the distal rings are okay. So this is one of the scenarios that the children present to us. So of course we advised a laryngotracheal reconstruction, but the parents refused to do anything for the child because they had already lost a lot of money, time on their previous seizures, this NICU management that he needed, and transferred to multiple centers. So we lost this baby to follow up. So the lessons, though, with every case we learn few lessons and we grow over the time. So we learned that we do get a lot of acquired stenosis on congenital laryngeal webs. This results in posterior scarring, which makes life more difficult to for us as well. We lose good mucosa, that Dr. Rutter pointed out. And early tracheostomy in remote centers is still a thing that not everybody has learnt, at least in remote places of India. So this is another case in a better scenario, in a scenario where we are well equipped. This is a child who was born aphonic. He had no or minimal distress. On day 2 of life, he was taken up for an anal dilatation for an anal atresia under general anesthesia. But the anesthetist said that he couldn't intubate. So because it was an experienced center, he did not attempt any intubation. He put in an LMA and he started the surgery. He allowed the surgeon to complete it, and he immediately gave a call to assess the airway. So on day 3, the airway was assessed when the child was 2.7 kgs. So this was a congenital laryngeal, severe grade of congenital laryngeal web. So at this stage, what we did was we did a tracheostomy, and I'll point out the reasons why. So yes, because we would prefer doing a double stage surgery later. We would want a trach to be in there because we want to place a stent. We would like to clear out all the retained secretions in the distal trachea and protect damage to the lung, because a lot of these children are not able to get out that secretions. So once you put a trach in, you are able to suction the trachea and the distal lung. You will allow the child to grow and gain some weight, because we don't want to operate at such a young age. You get time to work up for other anomalies which are associated with congenital laryngeal webs, and in the meanwhile you can also treat them as the child grows. We allow parents to arrange for funds for these kind of major surgeries. So this is a real scenario for us where we have to give them time to understand the problem and arrange for funds. And then meanwhile we can train the parents for track care as well, because they are going to be on a track for a long time, so they need time to adjust to the scenario. So we called him at 1.5 years of age, and we did a formal airway assessment where we can see the arytenoids are mobile, and it's a thick web with a large subglottic component. In fact, we couldn't pass a 2.7 mm scope below, but we can see that this is pristine mucosa over the web, and because an attempt of intubation was not made, it's a virgin web, easy to operate. The distal trachea also looks fairly okay. So what we did was a double stage LTR with an anterior costal cartilage grafting with stenting. The stent used is the Monniers laryngotracheal mold, and an anterior graft is put over it. So this is the airway, how it looks like after stent removal. So yes, the technique used was same as Professor Rutter described, that we cut the web in midline and we use the two flaps created by the web to close over the thyroid ala, and this gives a very good V that we are seeing in this video. So the lessons learned from this case are: do not attempt multiple intubations if you are not able to intubate in the first sitting. After cutting the web, suture the free edge of the web to the lower border of the thyroid cartilage to create a good mucosal cover. This will improve the voice of the patient. Submucosal shaving of the cricoid to reduce the thickness. This is something that we learned, that we can use a drill, or sometimes it is so soft it cuts like butter, and we can just shave it off submucosally. This will prevent any mucosal damage in the subglottis. Always try to maintain the anterior commissure in the right position before closing. This is what Professor Rutter also showed. And we need stents for these. If there is some exposed mucosa, then a stent will help prevention of granulation formation. So this is another case. He was born with a weak cry, there were no scopy findings. The child underwent a tracheoesophageal fistula surgery, underwent multiple intubations for dilatations, failed surgeries and all. Every time the child got extubated, he developed stridor, but nobody bothered to look at the airway. They tried to continue saving the child by multiple gastric procedures. So in the end, after 2 years, when the child was taken up for a esophageal dilatation, finally when they couldn't intubate, they did a scopy and found that there is an anterior commissure web. So here, then he was referred to us when the child was 2 years and 2 months old. The history was very typical. It's hoarse voice with mild stridor only at night. So the patient does not have significant symptoms. There is a component of subglottic narrowing as well. So this is probably an acquired on congenital variety again, not purely congenital, but because the child was doing well and the child was only 2 years of age and did not have multiple problems, that was his last procedure. So then we decided to wait and watch, and incidentally the father was an anesthetist, so he said that whether we have the option of waiting and watching, because he had read that that's an option. So yes, we actually waited. He annually followed up with us, and now after 9 years the baby is growing well. The voice has improved with time, so the web did not require any intervention, and the child is doing well. So we learned that an early flexible scopy for all children with weak cry, this point has to be conveyed to the pediatricians who are present at the time of delivery, that weak cry is an important symptom. All these children are born with abnormal cries. Scopy is also indicated before every tracheoesophageal fistula repair, because these children have multiple other anomalies. Scopy is also indicated after multiple intubations, because there is a component of injury, acquired injuries, and also after every post-extubation stridor. And as Professor Rutter said, that vigilant watchfulness in type 2 can also work, so not every web would need a surgical excision. So now we are also evolving with every case, and we are trying to develop newer ways of dealing with these things. So this is an example of that. In 2021, this baby, a term baby with normal delivery, but mother had a unicornuate uterus and prolonged labor. So the child was born limp or hypotonic at birth. They tried to resuscitate with bag and mask and shifted to an NICU. He developed some seizures. They tried to intubate with difficulty. Now this history is very important, that they intubated the child but with some difficulty. He was stabilized, he was extubated and put on CPAP. Then he developed sepsis and needed an intubation again. So every time he needed an intubation, there was a stridor after extubation. Finally, so after 20 days, they finally referred this child for a bronchoscopy. So this is after the bronchoscopy, they realized that there is a web, and this child came to us only after 1.5 years in January. So when we did this airway assessment, with flexible, we could see that the cords are mobile, but with this view, we cannot get the actual picture. We have to actually put in a vocal fold retractor, and when we put this vocal fold retractor in the ventricle and kind of separate it, we know that this is a full thickness acquired on congenital laryngeal web. I would say that acquired on congenital, because we see some scarring around here. We see it's a total stenosis, and there are some fibrotic bands here. So this is an acquired on congenital variety again. So we see more of these cases. So again, we did an LTR with anterior conchal cartilage graft. Now I'll say why we use conchal cartilage, because we realized that it's very easy to submucosally shave off the cricoid cartilage, and the thickness kind of matches with the concha of the child at that moment. So we tried this because it's an easier procedure. It has lower morbidity as compared to the costal cartilage. Of course, a thyroid ALA is another option, but we tried this. We had already explained the parents that we can use any form of cartilage, whichever is available. So after putting this is how we suture it. The suturing technique is similar to the anterior costal cartilage grafting, and this is after the mold removal. We see that a very good anterior commissure is maintained. The subglottis is good. This is the tracheostomy tube, and the child got decannulated after 2 months. So these patients are doing well. So what we learned is, in any difficult to intubate situation, the pediatrician or the intensivist has to inform an ENT immediately and call for a scopy. Conchal cartilage can be a good option as against costal cartilage, though I'll show my data. It's easier to harvest and has less local morbidity. We've done 4 cases of anterior conchal cartilage grafting with stenting, 2 for laryngeal webs and 2 are for isolated subglottic stenosis. All 3 have done well and 1 is awaiting stent removal. So maybe conchal cartilage is one of the options that we can give if some patient is not fit for an costal cartilage, or if costal cartilage is difficult to harvest for a team of setup, then all otologists are trained to remove conchal cartilages. So this is my last case. This is a 2-year-old female born with aphonia. She was advised that her voice will improve with time. So this is also one of the things that generally we see in our practice, that they say that as the child grows, the cry will become better. The baby was growing well, and after 1 episode of URTI at the age of 2 years, the child presented with stridor. Though it settled with medical management, but it kind of alerted the parents that there might be something wrong. So they went to the pediatrician, who referred them to a local ENT person. He said that this is a type 3 membranous web on a transnasal flexible scopy. And they suggested that an endoscopic excision should be done because it seems like a thin web. But they luckily got the CT neck done, which showed a minimum subglottic narrowing. So when this patient came to us in July recently, we said that no, for every membranous web we have to put in a scope and see the subglottic extension. So if we see the web seems membranous, but there is a thick subglottic component, and it seems like when we sized this airway, we couldn't pass a 3.5 mm tube for a 2-year-old child. So yes, there is significant subglottic narrowing. So this child, again, we have done an LTR with conchal cartilage grafting, and incidentally this child also had this chromosomal 22q deletion and was diagnosed with DiGeorge syndrome. So sometimes we tend to miss out on these cases, but these are there are some lessons to be learned. Like, these patients can present late, especially in our country. Flexible endoscopy followed by careful assessment of the subglottic component is the key. Always size the airway, because sometimes you feel that the subglottis is normal, but once you try to size it, you realize that it's a significant grade of narrowing. And parent counseling and training for track care is essential. So this is in a nutshell our data of 9 cases over 8 years. We don't tend to see many grade 1s and grade 2, probably because of the initial bias of not doing many flexible endoscopies. But grade 3 and 4 with our treatment of LTR with anterior grafting gives fairly good results as compared to the costal cartilage as well. So to conclude, in India, there's need for awareness, there's need for training centers, and there's need for better stents to be available to all of us. Thank you so much, everyone, for your patient listening.
Thank you, Dr. Anju.